and 6th most leading cause of death worldwide. Asia, 45% of all pancreatic cancers are in Asia, and the mortality is almost same per year. This data is from Global Cancer Observatory. If we talk about the distribution of the pancreatic cancers, mainly they arise from the head of the pancreas, and some of them arise from the neck and the tail. All right. If we talk specifically about neuroendocrine tumors, they are distributed from head to abdomen, and we can find multiple lesions involving multiple organs in the neuroendocrine syndromes or familial cancers. So, 2% of all pancreatic cancers are neuroendocrine tumors, and 3.6% of all neuroendocrine tumors are pancreatic NETs. This makes them slightly uncommon. Uh, if we talk about the distribution, 80% cases are sporadic. They are, involving the pancreas only, and in 20% cases, they are associated with the syndromes like multiple neuroendocrine endocrine neoplasia MEN1. This is mutation of MEN gene, and this may be associated with VHL 10 to 17%, neurofibromatosis type 1, and tuberous sclerosis. So, among these syndromes, pancreatic neuroendocrine tumors are mainly associated with MEN1, involving the pituitary, parathyroids, and pancreas. So, if we talk about VHL syndrome, which is the second most leading syndrome, it can involve all of these organs involving the cerebellum, retina, adrenals, and the pancreas, involving kidney up till the testicles. Further, mainly we will be talking about the familiar pancreatic neuroendocrine tumors, because this is a neuroendocrine surgery session, and this is a big statement, this is a bold statement I'm going to commit, which says these are incurable, lifelong tendency to reoccur. 90% are seen on the autopsy, and they are identifiable in 60% cases only. All right, they used to be detected in 40s earlier, if we talk about 2 decades ago, but now we can find them in 20s. So the disease is coming in the earlier age with the passage of time. If we talk about sporadic pancreatic neuroendocrine tumors, they are very much curable, they are very much treatable with good long-term survival. A quick talk about the classification. This is WHO classification of neuroendocrine neoplasms. They can be well differentiated or poorly differentiated. If they are poorly differentiated, a very poor prognosis is accompanied, and they are usually metastatic at the time of presentation. But if we talk about the well differentiated, they are graded on the basis of mitotic index, pleomorphism, and chromatin index. Ki67 index is a very useful marker regarding the differentiation and regarding the prognosis of the tumor. So we frequently use this indicator. Further, they can be functioning or non-functioning. What is a functioning pancreatic neuroendocrine tumor? Which a neuroendocrine tumor which is being secreted, which is secreting a certain hormone which is causing a symptom. But without those symptoms, if the hormonal levels are high, these are not considered functioning tumors. So, we need to differentiate on the basis of this to treat in the perioperative settings. However, the surgical principles are same for both of them. Further, if we talk about the incidence on individual basis for the functioning neuroendocrine tumors, Non-functioning are more common, but they are still, rare, 3 to 4 per million. Insulinoma among the secretory ones, 1 to 2 per million. Gastrinoma are the same, have the same incidence, and glucagonoma and VRPoma are less common among these. If we talk about non-functioning cancer, the symptomatology, it is very much non-specific. They can have only stomach ache, they can have jaundice depending upon the location of the tumor, unquantified weight loss, early new onset obesity and diabetes. So, a non-specific symptoms and symptoms of pancreatic insufficiency, which includes, greasy stools, and these are the symptoms in non-functioning tumors. But if we talk about functioning, they have specific symptoms. In insulinomas, neuroglycopenic symptoms predominate. In gastrinomas, they may have heartburn, water brush, diarrhea. These are the predominant symptoms. In glaucogonoma, a specific eczemic rash can be seen along with hyperglycemia, and VIPoma are associated with watery diarrhea and frequent episodes and weight loss. So this is a bit boring part. I just want you to be with me through this part. We are talking about guidelines, and the most specific guidelines for the pancreatic neuroendocrine tumors are NCCN guidelines so far. For a non-functioning tumor, a non-functioning tumor is a tumor which is not causing symptoms irrespective of the hormonal levels. If we talk about the investigation, there is one standard investigation for all of these functioning tumors, which is non-functioning tumor and functioning tumor, which is CT and MRI, multiparametric. And apart from that, we can switch to other specific studies if there is diagnostic dilemma, which include EUS, biopsy, and PET-CT. So this part is almost same for all the tumors we are going to talk about. So on the basis of these investigations, we decide if it is locoregional or metastatic disease. If it is resectable, then we need to resect it for non-functioning tumor. We can only observe the tumor less than 2 centimeter. The range has changed for the non-functioning tumor. It was 5 centimeter, and before that, in last few decades, we used to observe the tumor less than 5 centimeter, but now it's 2 centimeter. Depending upon the site of the lesion, we either go for pancreatic duodenectomy and lymphadenectomy, or we go distal pancreatectomy. If it is unresectable, there are other treatment options available. If we talk about insulinoma, in addition to CT and MR, we have other investigation which includes proinsulin level and C-peptides, which tells about the activity. And in addition to that, we can do a selective arterial calcium stimulation test for the localization purpose. So I need 10 more minutes. All right. So if you are able to localize the insulinoma, and if you are able to enucleate that, just do that. Do a parenchymal sparing from a surgeon's perspective. If it is deeper lesion, we should go for a definitive treatment, which can be a Whipple's procedure or a distal pancreatectomy. For glucagonoma, the algorithm is same. First, diagnose them, localize them, and then resect them if they are resectable. If they are unresectable, the treatment is medical. For VIPoma, VIP levels are different and the electrolytes are different. Otherwise, they are same. All right, the boring part is over. I mean, we'll talk about gastrinoma. They occur between the age of 20 and 15, male predominance. A gastrinoma triangle, which is between CBD, duodenum and neck of pancreas, they are mostly found in this triangle. 10% are exception, they can be found outside those. Their pathophysiology is hypersecretion of gastrin level, which activate, increase the acid secretion from the stomach cells and causing peptic ulcers. This is also called as Zollinger-Ellison syndrome. So the algorithm is almost same. Just talk about a case from a live case from our practice. We had a patient. He was 23-year-old male, had reflex symptoms, vomiting, loose stool, altered bowel habit for last 18 years. And further, he was a young patient, mind you. He was, just 23, 25 when he presented to us. He has an epigastric mass present. Ultrasound was done around 10 years ago, but that was not available. They were stating that he was having symptoms of water brush, um, reflux symptoms, which were, only responsive to omeprazole. When he used to miss those doses of omeprazole, he had, episodes of vomiting leading to hospitalization and IV medications. He had a surgery for a gastric ulcer perforation about 9 years ago when he was around 16, and his medical history was significant for omeprazole use. His family history was unremarkable. So our patient was basically an athlete, a young athlete. This is with the permission of the patient. When he presented to us, on examination, thin, lean patient with good build. There was a transfer scar on his abdomen with no visceromegaly. Upper GI and lower GI endoscopy were done outside, which were non-specific. A CT scan was done, which showed multilobulated heterogeneous mass in the gastrohepatic recess. Uh, it was abutting the Keys vessels, SMA, portal vein, uh, and other major structures, including stomach and pancreas. Ultrasound guided biopsy outside our hospital was done earlier, which showed neuroendocrine tumor grade 1. So he was being offered, surgery outside our hospital. When he came to us, we took him to the MDT. Um, we did EUS and MRI, and we planned surgery if it is resectable. So this is a picture of our EUS, which is showing a heterogeneous mass. The surrounding structures are not clear on this picture. However, this MRI is showing a gastrohepatic recess mass, an unusual site opposing the stomach and the liver. So on this MR picture, we can appreciate that it is inseparable from the pancreas. So initially we thought this might be a pancreatic lesion because, and the patient's symptoms rose the clinical suspicion of gastrinoma. So we went for gastrin levels which were 16 times higher than the normal level. So our diagnosis was gastrinoma, and we thought it is arising from the pancreas, and we are going to resect the pancreas doing distal pancreatectomy. So these are the basically bases on which we decided this is a gastrinoma. But I'm skipping some parts. We planned surgery. Initially, we thought we'll go for minimal invasive distal pancreatectomy, which we do routinely. But due to the previous surgery and expected, adhesions and the structures involved by the lesion, we opted for direct open surgery. This was our incision which we planned. This is the mass located between the stomach and the liver. Over this is the mass, and we all can recall this is area of portal triad on the right of this, and key vascular structures are in the vicinity. And there was another lesion in the segment 4B, which intraoperative ultrasound was done. As gastrinoma, there can be multiple lesions, and we try to locate that, but we were unable to find any lesion except in the segment 4B. So we mobilized the lesion, This is only attached to the stomach, and we took that segment 4B lesion out as well. This is the final specimen, a huge size for a gastrinoma, almost 5 to 10 times huge. Our operating time was 2 hours, less than 100 ml blood loss. Patient was discharged after 4 days. Just a few minutes after the excision of the mass, his gastrinine level was done, which fell from 1800 to 180 and then later on to 79. Final histopathology showed WHO grade 1 lesion. A PET scan was done which showed no residual disease. So, I will jump to the outcomes. He is symptoms free. It's been 1.5 years from now. No more medications. He is gaining weight and is returned to physical activity. He is back to the arena, our Olympic patient, and he is doing his, routine practice. When we reviewed the literature, just 2 minutes, sir. When we reviewed the literature, we were surprised that this is the rare side. There was no documented case so far of this side of carcinoma, an unusual size. If we talk about surveillance, 6 to 12 months for 10 years is surveillance for neuroendocrine tumors. If the tumor, all right. If we talk about prognosis, it is greater than 90%, 10-year survival if we completely resect, and 57% if incomplete resection is done. In the sporadic cases, metastatic or non-metastatic surgery is the treatment, but in familial cases, initially they used to treat them conservatively. Then a radical approach in last decade was there, a Whipple procedure or distal pancreatectomy. Now the evidence is evolving in the favor of more conservative surgery, parenchymal sparing technique. Patient-elder approach is necessary. Parenchymal sparing surgery in familial cases should be considered. Quality of life should be the priority. So our patient has joined back the arena, and much more are doing the same. We are proud that we are treating such kind of patients. Thank you so much.
Thank you, Dr. Zulqarnain. We are very short in time because most of the session has to start right away. I would request all of the panelists to come over on stage and